Good evening and happy Memorial Day, and welcome to another episode of Fresh Natural Live. We have a great show for you tonight. We're going to be talking about non-alcoholic fatty liver disease. It's thought to be one of the more, perhaps the leading cause of liver failure now. I'm seeing a lot of patients in my clinic with this disorder, and it's a fairly complex disorder. I think there are a number of theories in terms of the multiple mechanisms, and we're going to get into this. I think this is going to be a very important topic for you. And of course, most of you are taking the holiday off and enjoying your weekend, so maybe you'll be watching this on recording, but however you get this message, I think it's going to be very important to make a note of it. We're going to give you a lot of practical insights and ways of having your own health evaluated for this disorder. And of course, always pass this information on to loved ones. So sit back, relax, get your pen and pencil ready to go. We have a lot of information for you tonight. Okay, and welcome back. So, as I said, we're going to be talking about non-alcoholic fatty liver disease. I have on the show with me friend and colleague, Sosa. Ms. Sosa, how are you this evening?
I'm all right. I'm okay.
Now, you are back you've been all over the world between here and the continent of Africa. So where are you now?
I'm in Fairfax, Virginia.
Okay, Fairfax, Virginia. Okay, great. Yeah, how's the weather out there?
It's interesting. It's a little temperamental, not as warm as Houston, but it's been warmer the past couple of days.
Wow. What are some of the low temperatures you're getting there?
I think we were even getting like a 59, 60 on certain days.
Okay.
Yeah, so it's not that bad. I like it a little bit warmer because I just came from Africa and it was like scorching hot, obviously. So for me, it felt cold when I got here.
Yeah, you get acclimated to the heat and you come down to 60 degrees, makes you shiver.
Yeah, exactly.
Yeah. So anyway, as I said, this issue of non-alcoholic fatty liver disease is I think a very important issue. You know, and I know in your consulting practice, you see a lot of patients with chronic illnesses, and certainly in my medical practice, people with heart disease. They don't come in just with heart disease; they come in with a package of disorders. And, there are certain organs that are very important, that are central to the body's overall machinery and mechanism, and the liver is probably as central as organs get. It's the metabolic machinery. It's where the body manufactures, protein, hormones, nutrients. It has an important role in the immune system and the like. So when the liver is compromised, you can see other parts of the body's function compromising. And I think if we understand that concept, I think it's going to help us understand some of the phenomena that's related to non-alcoholic fatty liver disease. So what I'm going to do for the first part of our discussion is to go into an overview of non-alcoholic fatty liver disease. I'll make some comments on benefits of omega-3 fatty acids in the context of non-alcoholic fatty liver disease. And then we'll take a break and then come back and just have a discussion about this. And I'd like to get your intake on this as well as Sosa. So just to get started, non-alcoholic fatty liver disease. So what is this phenomenon, and what do we need to know about it? In essence, it's characterized by excess fat accumulation in the liver, hence the name, fatty liver disease. Now, the non-alcoholic is an important part because, I think most of us are aware of the adverse effects of excess alcohol consumption on liver disease. And so we're accustomed to, knowing about someone who's chronic alcohol consumption, who then develops, liver cirrhosis and therefore, advanced liver disease and the like. And so the non-alcoholic fatty liver disease is categorized as a separate entity because this whole class of liver disease is associated with multiple factors that one cannot necessarily pinpoint to one etiology, such as alcohol. It's estimated to affect about 10 to 35% of the adult population worldwide. Most common cause of liver disease in the United States. And it's independently associated with a risk of cardiovascular events and increased mortality. Now, the increased risk of cardiovascular events, I'm going to, share some of my thoughts on that in terms of how that might be the case. Studies show that those with non-alcoholic fatty liver disease consume about 27% more meat compared to with the general population. So that's something to, hold on to as we talk about the pathophysiology here. Triglycerides and other fats accumulate in the liver with excess dietary consumption. So, that's sort of a first hit mechanism, is accumulation of liver in the dietary area. This impairs the ability of hepatic cells to take up glucose. So fat accumulation resulting in insulin resistance. And then here we go with the mitochondria again. So the mitochondria, which are the powerhouses of cells, they become impaired. Now, if you remember from our previous discussions, and again, I'm always tie in these, common mechanisms. Previous discussion, we talked about inflammation of the heart. We talked about inflammation and kidney disease and previous discussions. Here we have inflammation with the liver and mitochondrial impairment. If you remember from our previous discussions, is associated with increased reactive oxygen species. These increased reactive oxygen species are like, cause oxidative stress, which, can contribute to ischemia, contribute to inflammation. And here you see this association with mitochondrial impairment associated with fibrosis. So that same common mechanism, increased oxidative stress, increased inflammation, and increased fibrosis is happening here in the liver, similar to where it happens in the heart and other organs. Furthermore, you have fat tissue accumulation in the liver. This represents it results in a release of pro-inflammatory and pro-thrombotic cytokines, IL-6, TNF alpha. Again, remember these cytokines. We talked about increased inflammation of cytokines and inflammation of the heart, increased inflammation of cytokines and other types of inflammatory conditions. And so here we're dealing with the same underlying mechanisms. And so when we talk about, say, disease A versus disease B versus disease C, and we say, well, the same mechanism are involved in disease A versus disease B versus disease C, then it's important to understand that these diseases are very similar. And to some extent, we can, consider them as the same disease. They have the same underlying manifestation. Now, this same underlying inflammatory process, excess cytokine release associated with that, in one individual may manifest as heart disease, and another individual may manifest as liver disease, someone else perhaps kidney disease or the like. And so, we have to consider that, hey, wait, there's the same underlying mechanism. It's just that one person may be predisposed to a hepatic manifestation versus a cardiac manifestation. So here we have the same mechanism that we talked about before. Excess adipose tissue in the liver also reduces release of anti-inflammatory molecules like adiponectin. So there's an overall systemic increase in inflammation when you have this process of underlying non-alcoholic fatty liver disease, which is resulting in these mechanisms. So here's an overview, and oftentimes a picture is worth 1,000 words. You have hepatic insulin release Okay, and that's increased gluconeogenesis or glucogen production, exaggerated lipogenesis and inflammation. That's happening intracellularly at the hepatic level. Muscle insulin resistance, abnormal myokine levels. So you have insulin resistance at the muscular level that is associated with hyperinsulinemia, which further feeds into this increased hepatic insulin resistance. You have more adipose tissue insulin resistance. Lipolysis, free fatty acids are released systemically, which cause systemic inflammation. You have abnormal adipokine levels, which has a hormonal factor associated with this metabolic process. Further inflammations occurs at the gut level. Patients with non-alcoholic fatty liver disease has the leaky gut that's associated with dysbiosis. Now, you can question, again, with the initial hit mechanism being poor dietary intake, are you developing dysbiosis first, or is one of the earlier mechanisms with leaky gut and a systemic inflammatory process that then hits the liver systemically? That's certainly a possible mechanism. So we're talking about association. So leaky gut being associated with non-alcoholic fatty liver disease could be a mechanism by which the leaky gut may be contributing to it. So it could be an early hit mechanism and an early pro-inflammatory mechanism. Overnutrition, as we alluded to earlier, increased take of fructose and sucrose, as well as increased intake of saturated fats. There's a neurohormonal component that's likely mediated by certain hormones. Satiety and preference appetite is associated with these neurohormonal levels, and increased fructose on the nutrition level contributes to the neurohormonal effects. Another aspect of the pathophysiology I wanted to outline is the progression of liver disease. Now, it doesn't necessarily progress in this order that I'm showing you, largely because we make the diagnosis at different levels. So we don't always see this progression necessarily, even though it may progress. So for instance, here you see a normal liver and the first hit of insulin resistance that's likely mediated by dietary consumption. But I don't want to leave out pharmacology, even though it's not in this diagram. Polypharmacy certainly contributes, I think, as a first hit mechanism, or potential as a first hit mechanism, to transfer from a normal liver to a diseased liver. So you can have a disease process where you have macrovesicular steatosis, so just fat accumulation in the liver cells. Or in some cases, we see what appears to be a progression straight from a normal liver to fibrosis. So you can have just early fat accumulation without fibrosis, or a combination of fat accumulation with fibrosis, and whether or not you can jump from normal to fibrosis with fat accumulation, or you progress with fat accumulation first and have fibrosis second, is thought to be two possible mechanisms. I can see how the fibrosis can occur with fat accumulation, independent of just fat accumulation only, because if you look at our initial mechanism, poor dietary intake or pharmacology, and you look at leaky gut, the leaky gut is releasing molecules that cause systemic inflammation, and therefore you have a result of inflammation of the liver. So you have more fibrosis, which then leads to advanced scarring, which we consider cirrhosis, and then hepatocellular carcinoma. Now, again, does it always go to hepatocellular carcinoma? Not necessarily. In fact, sometimes you can have hepatocellular carcinoma be an early hit mechanism. And so, and you can also have non-hepatic cellular carcinoma, other cancers contributing to this process. Why would that be the case? Well, if you have early hepatic dysfunction, because think of it as this way, you're getting hepatic dysfunction early on, even with macrovesicular steatosis and early fibrosis. So in these early stages, you're getting impairment of liver function. So when you have impairment of liver function, that's also a suppression of the immune system. We have suppression of the immune system that predisposes to infection and also cancer. So early on, you can get a secondary effect due to early hepatic dysfunction. We know that vitamin D is metabolized in the liver, so you have impaired vitamin D metabolism. We know that antibodies are formed in the liver, so you have impaired antibody formation, and there may be other systemic mechanisms that's impairing the immune system outside of the liver. So this early phase can jump clearly to either cancer of the liver, or it can jump to cancer of, say, the colon, metastasis of the liver, that then will lead to this progression. Not to overlook that the individual may continue to consume toxic chemicals such as toxic foods and toxic medication that further impairs liver function. So you can get severe hepatic dysfunction early on, even before you have this pathophysiological progression. So that's why the progression is not as orderly and neat as this diagram shows, because you have multiple hit mechanisms that are occurring simultaneously every stage of the way. And I hope I didn't lose people. I hope, get your questions ready regarding that. Clinical overview, what often is considered, they think of cardiometabolic outcomes. So some of the manifestations leading to poor health and death of patients with non-alcoholic fatty liver disease, cardiometabolic causes as the highest contributing factor. Oncologic and primary hepatic dysfunction are also categories that are considered the major categories that we consider. I will mention that from a cardiovascular standpoint, certainly in my patient population, I see a lot of patients with cardiovascular dysfunction, such as advanced heart failure, which leads to congestion of the liver. So you can have what we call as a congestive hepatopathy. So we have increased pressure on the liver due to poor circulation or increased right heart pressure, secondary to increased left heart pressure, secondary to heart failure or weak left heart or stiff left heart. You can have congestive hepatopathy. You can also have patients with valvular disease, such as tricuspid valve disease or pulmonic valve disease, that again results in backflow congestion, and you can have liver cirrhosis as a result of that. So we see it's common in my situation. In fact, all my heart failure patients are evaluated for underlying liver disease, even though they may have normal liver function tests, because we're looking for a cardiovascular contributing factor to hepatic dysfunction. So having said that, patients coming in with standard chronic metabolic disorders. So let's say someone is obese with metabolic syndrome, has insulin resistance, but they also have heart failure, because the same mechanism causing insulin resistance or causing diabetes is contributing to heart failure, giving them coronary disease, heart attacks, but it's also directly affecting the liver through the same mechanisms that we described. So you have someone with cardiovascular contributions to liver cirrhosis or fat accumulation in the liver, plus direct metabolic contributions to it. And so the liver is getting it from every angle, if you will. So some people looked at the role of omega fatty acids, and we'll talk about this briefly and kind of give an overview of nutrition as it pertains to omega fatty acids and in general. And I'll share some of my thoughts and get Sosa's comments on this in our next session. But omega-3 fatty acids include polyunsaturated fats derived from alpha-linoleic acid, pentanoic acid, and docosahexaenoic acid. And these are fatty acids, ALA or alpha-linoleic acid, found in land plants. EPA and DHA are found primarily in algae and fish, but the fish get it from the algae. So essentially it's found in sea plants. So the way I like to think of it is ALA is found in land plants, and EPA and DHA are found in sea plants. EPA and DHA are anti-inflammatory and found in algae. Our body can convert ALA to EPA and DHA. Some people convert it better than others due to perhaps genetic differences. Plant foods like chia seeds, flax seeds, chia seeds, walnuts, and vegetables are also good sources of omega-3. So I tend to tell patients to consume a good amount of land plants and a good amount of sea plants, i.e. algae. Say blue-green algae or microalgae, and the sea vegetables, larger sea vegetables are macroalgae. Omega-6 include polyunsaturated fats derived from linoleic acid and gives rise to arachidonic acid, which can be pro-inflammatory. So you need a proper balance of 3 to 6. The pro-inflammatory effects are beneficial because the body do need some ability to create inflammation, but it has to be kept in balance. And so the optimal ratio is thought to be 3 to 1, omega-6 to omega-3. And higher than this ratio can predispose to excess of inflammation. And a lot of people in the standard American diet are getting an excess amount of omega-6 compared to omega-3. And so the total amount of omega-3 acid is crucial to reduce oxidative stress. So what are the effects of omega-3 on lipid levels? Omega-3 acids have an effect on gene expression. So there's a genetic mechanism. It causes a reduction in production of endogenous fats and a breakdown of dietary fats. So omega-3 acid can increase the action of the peroxisome proliferator activator receptor alpha. This causes a breakdown in fats, and it causes a stop in progression of reverse fatty liver disease. There's also an effect on the gene transcription factor of the steroid regulatory element binding protein 1, or SREBP, to reduce lipid production by the liver. Suffice it to say, there's a genetic mechanism at which the omega-3 is working to have an effect on liver fat metabolism. Omega-3 acids also affect molecules across cell membranes. So the transporter molecules across membranes and the similar fashion transporting glucose across cell membranes can be enhanced by omega-3. So it can improve insulin resistance, possibly independent of insulin levels. And so since glucose going into cells, the liver will not be triggered to produce or release more glucose or triglycerides in the bloodstream. So increase omega-3, increase glucose transport. So having a counter effect on insulin resistance. Now, the one mechanism in which it lowers is that it lowers serum triglyceride levels and glucose. So that decreases fatty uptake. It can reduce LDL and VLDL and increase HDL. Omega-3 also reduce inflammatory markers like TNF alpha. And these inflammatory markers, a reminder, serve as signaling molecules to trigger more inflammation. So it can interrupt that cascade of inflammatory molecule stimulation. So omega-3 fat increased nitric oxide release from the endothelium. That has benefits from a cardiovascular standpoint, which is important. So consuming omega-3 fatty acids, good sources, as we alluded to, flax seeds, chia seeds, walnuts, of course, sea vegetables like algae, also good sources. Broccoli, spinach, cauliflower, Brussels sprouts, bok choy, turnips, edamame are also good sources of omega-3 fatty acids. Now, people like to talk about fish consumption, and fish has high levels of omega-3 fatty acids. Remember, the fish get it from the algae. Not only that, the fish has a lot of bad molecules in. Fish consumption is associated with increased trimethylamine oxide, which is associated with transporting bad lipids, cholesterol, and promoting atherogenisis at the endothelial wall, in the endothelium and the arteries. So the negative aspects of consuming fish outweigh the positive. There was a review of 27 studies show increase in plant-derived sources of omega-3 reduced cardiovascular disease by 10%. So in conclusion, overall lifestyle change are the best way to currently help prevent and reverse non-alcoholic liver fatty disease, because liver disease worsens in metabolic syndrome. So again, the nutritional approach is going to be the ideal way of doing this. Lifestyle change, reduce fatty liver acids, avoid processed foods that contain trans fats, avoid high amounts of saturated fats, avoid processed sugars, excess carbohydrates, lose weight, eat a diet rich in antioxidants, and consume omega-3 fatty acids. And I would even argue the optimal lifestyle helps reduce the requirement of pharmacological agents. That's not listed in the usual article or review articles that you'll look at when discussing this. However, I think it's an important thing to consider because we often are quick to take an over-the-counter medication, whether it's acetaminophen or some other agent or drug. And we need to keep in mind that these drugs, many of them, most of them, have to be metabolized through the liver and can have an adverse effect on the liver. Also, chemical preservatives. So you may be consuming food that are quote unquote thought to be healthy, but processed oils and other processed foods with chemical preservatives, dyes, or the like can also have an adverse effect on the liver. So we want to keep these things in mind in addition to the food. So you want your food to be pure and natural and not overly preserved, etc. So what I want to do is take a quick break here. And Sosa, I want to get your take on some of these concepts, and then we'll also hear from the audience in the chat. So as we go to break, I want you guys to take a break, hit the thumbs up, show us some love with the thumbs up. Also, please subscribe if you haven't had a chance to, and share this important information because non-alcoholic fatty liver disease is a very common disorder, and it's like a thief in the night. It can sneak up on you. Many doctors don't screen for this. They check liver enzymes, and they may have you on a lot of medication that are metabolized by the liver. And they say, well, the enzymes are fine, so the liver is fine, but that's not necessarily the case. So give us a thumbs up. Please subscribe if you haven't had a chance to, and share this information. We'll be right back.